Welcome to the series where I'll be discussing the 2026 Consensus Statement on the Algorithm for Management of Adults with Type 2 Diabetes by ACE. This is Endo in a Bite, where I break down endocrine concepts or lengthy guidelines into focused, high-yield pieces you can actually remember. For the full board-centric framework, I've built it all out in easy endo prep, designed to keep you efficient, current, exam-ready, and sharp in clinic. Visit www.ezendoprep.com to enroll in the full course or start your free trial. When we talk about type 2 diabetes, one of the most overlooked complications is metabolic dysfunction-associated steatotic liver disease. This is an area that every clinician managing diabetes should be thinking about. The prevalence of this condition is remarkably high. Globally, about 65% of adults with type 2 diabetes have steatotic liver disease. If a patient with type 2 diabetes or metabolic syndrome has fat in the liver on imaging, does not have significant alcohol use, and no other obvious cause of liver disease, that is generally sufficient for the diagnosis. This condition was previously called non-alcoholic fatty liver disease. The terminology was changed because the new name better reflects what actually drives the disease. Rather than defining it by the absence of alcohol, the emphasis is now on metabolic dysfunction, which is the underlying cause in most patients. In simple terms, steatotic liver disease is the accumulation of excess fat within the liver in people with metabolic disease. It commonly occurs alongside obesity, type 2 diabetes, hypertension, and dyslipidemia. Importantly, this is now the most common chronic liver disease worldwide, but the consequences extend far beyond the liver. Patients have a higher risk of cardiovascular events, chronic kidney disease, hepatocellular carcinoma, other cancers outside the liver, and ultimately liver failure. Because of these risks, identifying, staging, monitoring, and treating this condition should become a routine part of caring for people with type 2 diabetes. The more advanced form is MASH. This represents progression beyond simple fat accumulation. In addition to steatosis, there is liver inflammation and injury to liver cells, placing patients at substantially greater risk for fibrosis, cirrhosis, and liver-related complications. Lifestyle intervention remains the foundation of treatment. Dietary modification, increased physical activity, and weight reduction should be emphasized for every patient. About 5% weight loss can reduce liver fat. Greater than 7 to 10% weight loss is typically needed to reverse steatohepatitis and improve or even reverse fibrosis. Alcohol intake should also be minimized, and for patients with moderate to severe fibrosis, complete abstinence is recommended. Until recently, the only medication with regulatory approval specifically for this condition was resmetirom, a thyroid hormone receptor beta agonist. Clinical trials demonstrated improvements in liver fibrosis as well as improvement or complete resolution of MASH. At the same time, growing evidence has shown that several diabetes medications also provide meaningful liver benefits. These therapies are now incorporated into recommendations from ACE and ADA. Among glucose-lowering therapies, GLP-1 receptor agonists should be considered first-line pharmacologic therapy for patients with steatotic liver disease. Weekly semaglutide at the 2.4 milligram dose recently received United States FDA approval for this indication based on the 72-week ESSENCE trial. MASH resolved in 63% of participants, compared with 34% receiving placebo. Fibrosis improved in 37%, compared with 22% on placebo. Importantly, many patients achieved resolution of steatohepatitis without worsening fibrosis, and about one-third experienced both steatohepatitis resolution and fibrosis improvement. Even before the ESSENCE trial, smaller clinical studies with exenatide, liraglutide, dulaglutide, and semaglutide consistently suggested benefit. In addition, network meta-analyses, including 14 clinical trials, have supported the positive effects of GLP-1 receptor agonists in treating this condition and MASH. Research is now moving toward newer agents that stimulate multiple hormone receptors simultaneously, including GIP and glucagon receptors, with the hope of achieving even greater improvements than GLP-1 receptor agonists alone. Let me discuss the current status of tirzepatide as of July 2026. In the Phase 2b Synergy-NASH trial, which enrolled 190 participants, tirzepatide produced impressive rates of steatohepatitis resolution without worsening liver fibrosis. Resolution occurred in 44% of patients receiving the 5 mg dose, 56% with the 10 mg dose, and 62% with the 15 mg dose, compared with just 10% in the placebo group. All of these differences were highly statistically significant. The study also looked at improvement in liver fibrosis by at least one stage without worsening of steatohepatitis. This occurred in approximately 51 to 55% of patients treated with tirzepatide, compared with 30% in the placebo group. However, it's important to remember that the study was not powered to definitively prove a fibrosis benefit after adjustment for multiple statistical comparisons. Despite these encouraging results, tirzepatide is not currently approved by the FDA for MASH. At present, its approved indications remain type 2 diabetes under the brand name Mounjaro and obesity, including obesity associated with obstructive sleep apnea under the brand name Zepbound. Larger Phase 3 trials are now underway to determine whether these promising findings translate into a future approved treatment for this condition. Another medication with substantial supporting evidence is pioglitazone. Multiple randomized controlled trials have demonstrated improvements in liver fat, inflammation, and hepatocellular ballooning. The effects on fibrosis have been less consistent, but the overall evidence supports a prominent role for pioglitazone in patients with type 2 diabetes who have steatotic liver disease or MASH with moderate to severe fibrosis. However, clinicians must balance these benefits against potential adverse effects. Pioglitazone causes dose-dependent weight gain, averaging about 1 to 2% with 15 milligrams daily and increasing to approximately 3 to 5% with 45 milligrams daily. This weight gain is related partly to fluid retention and partly to increased subcutaneous fat. Fortunately, combining pioglitazone with a GLP-1 receptor agonist or a SGLT2 inhibitor may lessen this weight gain. Pioglitazone should also be avoided in patients with New York Heart Association Class 3 or Class 4 heart failure, and clinicians should remember its association with bone loss, osteoporosis, and fractures, particularly in postmenopausal women. Evidence for SGLT2 inhibitors continues to grow. Randomized clinical trials have demonstrated reductions in liver fat with dapagliflozin, empagliflozin, and canagliflozin, primarily using MRI-based assessments. In addition, a post-hoc analysis of the Virtus cardiovascular outcomes trial found improvements in liver enzymes and reductions in hepatic steatosis with ertugliflozin. More importantly, biopsy data are now beginning to emerge. In the first placebo-controlled randomized trial using liver biopsy to assess outcomes, dapagliflozin significantly improved both MASH and liver fibrosis in adults with biopsy-proven disease, regardless of whether they had type 2 diabetes. The bottom line is this: steatotic liver disease affects nearly 2/3 of adults with type 2 diabetes and is associated with substantial risks extending far beyond the liver. Lifestyle intervention remains the cornerstone of therapy, with meaningful weight loss providing the greatest benefit. Resmetirom is the first approved liver-specific therapy. GLP-1 receptor agonists, particularly semaglutide, now have compelling evidence and regulatory approval. Tirzepatide has produced highly promising results, but is not yet approved for this indication. Pioglitazone remains an effective option in carefully selected patients, and SGLT2 inhibitors continue to accumulate encouraging evidence, with dapagliflozin now demonstrating biopsy-confirmed improvements in both steatohepatitis and fibrosis. This was another bite-sized episode of Endo in a Bite. If a detail went by too quickly, don't worry. I've prepared the notes for you. Visit www.easyendoprep.com to sign up for the weekly newsletter. and have all the key pearls delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and ABIM exam preparation. Remember, stay consistent, and together we'll work through the ACE consensus statement on the algorithm for the management of dyslipidemia, one bite at a time.